Good morning. It's an very hard act to follow these two amazing lectures that we heard this morning. But let me try. First, I want to thank you, John, and thank you, Charles, and to the members of the organizing committee for inviting me to be a part of this very important conversation at this very critical moment in history and the development and the exquisite execution of a regional African CDC. I want to thank all of you, healthcare professionals, policymakers, finance experts, scientists, and advocates who are leading the global effort to confront existing and emergent diseases. Like my colleague before me, I would like to also disclose that I have nothing to disclose. And I hope that what I will be able to do in my 25 minutes or so is give an overview that tries to paint the story, give a narrative that builds the case for why it is that we need an integrated platform approach to respond to prepare for emerging infectious diseases. As the people in this room well know, this work, you come from an area, a range of disciplines. We represent communities from across the continents where some of the scourge of disease is a looming threat. Others where it's a devastating, almost daily reality. But what we share is an acute understanding that preparing for the next outbreak is an urgent and global imperative. I want to start by invoking again some history. 100 years ago, the world found itself in the throes of one of the deadliest diseases in recorded history. The Spanish flu of 1918 began as a mild illness, sounding very few alarms. But within months, a second highly contagious strain had emerged, killing those who contracted it within days, sometimes even within hours. The people who succumbed to this illness were not just the elderly and the very young, but otherwise healthy young adults. At the time, scientists had not yet discovered viruses, so there were no laboratory tests that could detect flu strains. There were no vaccines to prevent them, no antiviral drugs to treat them, as you heard earlier, and no antibiotics to combat the secondary bacterial infections that so often followed them. The best hope for prevention at that time came down to rigorous hygiene, quarantines, and mass closure of public places like schools and businesses. Local governments took drastic measures to halt the spread as best they could. Even in some cities ordered everyone to wear face masks in Publix. And in some places, like New York, my hometown, where people were fined or even incarcerated for failing to cover their coughs. Yet, despite these measures, the pandemic took hold at incredible speed. At the time, World War I was coming to a close, and millions of soldiers were still traveling the world, inciting outbreaks at every port along the way. In less than 1 year, the flu had reached all but a few remote regions in the globe. And these remote regions included the American Samoa and Iceland, for example. The number of deaths overwhelmed hospitals and cemeteries on every continent. There were mass shortages of nurses and doctors, bodies piled up in makeshift morgues, and in the United States, the average life expectancy plummeted by more than a decade in just 1 year. All told, the pandemic, as you heard this morning, would infect 500 million people, and at that time, that represented 1/3 of the world's population, and claimed between 50 to 100 million lives. The economic and the social devastations continued for decades. There's no question that things have changed considerably since 1918. we've made tremendous achievements in human health, particularly our ability to combat infectious diseases. That's due to a number of basic but very critical public health measures. These include better sanitation, fresh water, and improved nutrition. It's also due to the advent of vaccines, antimicrobials, and supportive care. And yet, the lessons from 1918 still matter a century later, because in spite of all of our progress, pandemic disease remains one of the greatest threats to global security and to global stability, arguably greater than terrorism, war, or even natural disasters. Today, infectious diseases appear to be emerging more quickly than ever. Over the past 30 years, the number of annual global outbreaks has nearly tripled. In the past 15 years alone, we've seen Ebola, Zika, MERS, SARS, cholera, tuberculosis, HIV/AIDS, and various strains of influenza virus affecting hundreds of millions of people, as you heard from Professor Heyman's lecture. And we know why. We know why. We live in a world where human populations are increasingly connected, both with each other and with animals, which are responsible for the spread of about 3/4 of new infectious diseases. These connections create endless opportunities for pathogens to find new hosts, travel across borders, and evolve into stronger strains than we've seen in the past. Today, people and goods move faster and farther than any other time in human history. And so the same is true for disease. We know that a pathogen can spread from a remote village to a major city in less than 36 hours. And an epidemic in one corner of the world is just one flight away from becoming a public health crisis somewhere else. On top of the increased mobility, people are also living in denser environments. And for the first time in history, cities are home to more than half of the world's population. Without proper planning for hygienic conditions, urban areas become perfect breeding grounds for disease. And when health systems are weak, there's nothing stopping these diseases from thriving. Climate change, and I must mention climate change, is also helping to fuel the spread. For example, warming temperatures will expand the natural habitats of Aedes mosquitoes, which carries diseases like Zika, dengue, chikungunya. Researchers believe that bird flu, cholera, and Lyme disease will also worsen as temperatures continue to warm. Meanwhile, and we have to pay attention to this, antimicrobial resistance, or AMR, is undermining some of the gains that we've made in disease control. Infections like gonorrhea, tuberculosis, and foodborne diseases are becoming harder and sometimes impossible to treat as antibiotics become less effective against bacteria. The US CDC estimates that at least 2 million people become infected with antibiotic-resistant bacteria every year, and that AMR could cause 10 million deaths per year by 2050. So the next pandemic isn't a question of if, it's a question of when. And yet globally, we remain dangerously underprepared. Now, not to be mistaken, we have made incredible breakthroughs in our ability to prevent, detect, and treat existing and emerging diseases. But our health care systems are still alarmingly vulnerable. That's true in even the most developed countries. We are in this together. And even more so true in places where health systems are limited are disjointed, or are overwhelmed by the daily burden of emerging non-communicable chronic diseases. And I remember, Dr. John, we were talking about this in our meeting last year, that as we continue to manage and prepare for infectious disease, we do have to also keep an eye on and be mindful that whatever systems we build with the expectation that there is also the double burden of the increasing non-communicable disease on this continent and in other developing economies. So now I want to turn to talk about the 2014 Ebola outbreak. The outbreak in West Africa threw that vulnerability of our health systems in stark relief. The disease originated, as you know, in Guinea, but it took nearly 3 months for health officials to formally identify it. By then, it was already sweeping through neighboring countries of Liberia and Sierra Leone. Hence the importance of what you heard in the lecture before, the importance of a regional response. These countries are 3 of the most poorest countries in the world, and they were ill-equipped for the outbreak at nearly every single operational level. Years of civil war and unrest had more or less leveled basic health infrastructures. Weak roads and communication systems made it difficult to disseminate health alerts or transport patients to treatment. Yes, it was, and still continues to be, an engineering challenge. And unlike countries in equatorial Africa, none of these 3 nations had ever encountered Ebola before, so their clinicians had never managed such cases. Their labs had never managed these types of patient specimens. Their governments had never dealt with the social and economic upheaval that would follow the outbreak. And most importantly, their people didn't understand what was causing them to fall ill or why. The results, as we know, was a devastating perfect storm. In just over a year, there were nearly 28,000 confirmed cases between the 3 countries and 11,000 dead, including more than 500 healthcare workers. Thousands of children were left orphaned. And beyond the human tragedy, the disease had profound economic consequences. Locally, commodity prices fell, unemployment surged, food shortages took hold, and the aftershock and panic reverberated around the world. The West African 2014 Ebola outbreak revealed a number of painful realities, and these were: it showed how swiftly a virus can move when it reaches densely populated areas. It showed us that fear and misinformation are as contagious as the pathogens themselves. It showed that a fragile health system in one country can threaten catastrophe for others. And it showed that we lack the international capacity necessary to best respond. But it also showed us that the fight is not futile. One of the very few bright spots in the Ebola response came out of Nigeria. On July 20th, 2014, a Liberian man arrived in the city of Lagos on a commercial flight. He was so ill upon landing that he collapsed in the airport and was immediately transported to a private hospital. He initially told health workers that he had malaria, but when the malaria treatment failed, he was moved into isolation. 3 days later, he was tested positive for Ebola and eventually died. In a matter of weeks, some 19 individuals had caught the disease, including 9 doctors and nurses who treated the man at the hospital. But against all odds, Nigerian outbreak never evolved into a full-blown epidemic. All of the ingredients were there. Lagos, as you know, is the largest city in Africa, with a population of over 21 million. It's a major hub of business and travel. It's also a place where many poor people living in crowded slums and many more traveling in and out of the city every day looking for work. But ultimately, the catastrophe that was feared never materialized, and that's thanks to the country's strong leadership and its ability to coordinate a swift, aggressive public health response. On the same day the first patient was diagnosed, officials set up an emergency operations center to coordinate the effort between local officials and international NGOs. They opened isolation wards in the 2 infected cities, and they dispersed funds rapidly. Nigeria had a leg up in terms of experience with disease. Until recently, polio had been debilitating thousands of people each year. The country was able to repurpose many of the lessons learned and much of the infrastructure that was built from its polio eradication effort to respond to Ebola. For me, this is an exquisite example of building in public health systems a platform, an infrastructure that is nimble and responsive to both the communicable and non-communicable, the expected and the unexpected epidemics and threats that will come. So let's take a quick look at what the Nigerian infrastructure had to offer. It had a pre-existing surveillance system to track patients with disease. They also had a comprehensively high number of specially trained healthcare workers. Once officials identified everyone who had been exposed to the virus, these workers were able to canvass door to door, conducting more than 18,000 face-to-face visits to check for fever and other Ebola symptoms. Essentially, the investment in human capital in a public health system allowed for a capable, well-trained, well-supported workforce to do the work that is necessary for surveillance and contact tracing. And on October 20th, exactly 3 months after the infection reached Lagos, the World Health Organization declared Nigeria free of Ebola virus transmission. Eventually, the broader epidemic was brought under control thanks to determined healthcare workers and community leaders, along with robust support from the international community. Yet the costs were far greater than they could have been, and far more lives were lost than should have been. The 2014 Ebola outbreak was the deadliest in history, and it was also a very important wake-up call. It revealed a number of deficiencies in our collective ability to respond to infectious diseases. More than 40 reports were written in the wake of the crisis, and each of them outlined key findings, and I'll summarize here. First, that local health systems were overburdened. Second, that surveillance and alert systems were inadequate. Third, that governments and NGOs responded too slowly and haphazardly. And fourth, that communities lost faith in their local and national institutions and authorities. So even though the tragedy quickly faded from the headlines, funds to prevent future outbreaks receded. And in many ways, as life has moved back to normal, we have let our collective guards down. This familiar, and I would say dangerous cycle of panic, then neglect, followed by more panic, is not unique to Ebola. Across the globe, we are still seeing a reaction to a crisis rather than preparing for a crisis. After every outbreak, we see a flurry of proactive engagements. But eventually, political interest wanes, funding priorities shift, and attention goes elsewhere. In fact, we saw this play out in the US as the current administration walked back America's commitment to disease response. In the wake of the 2014 Ebola outbreak, the US Congress appropriated $5.4 billion to fight the epidemic. Most of it went to combating the outbreak. Around $1 billion was allocated to help developing countries detect and respond to diseases. That money has been used to train epidemiologists, to buy equipment, to upgrade laboratories, and to stockpile drugs. But sadly, this past May, just as Ebola was re-emerging in the Democratic Republic of the Congo, the White House asked Congress to rescind the remaining $252 million. That money had been set aside for building local capacity and improving surveillance capabilities to respond to future outbreaks. I would say that this type of short-term thinking imperils the entire world. It makes us more vulnerable to pandemics. It threatens to cost us billions of dollars and countless of precious lives. And we don't have the time or the lives to lose. History tells us that the next epidemic is only a matter of time. And that means that time to prepare, as always, is now. In the wake of the Ebola crisis, the National Academy of Medicine convened an international working group to do just that. The Commission on Global Health Risk Framework for the Future, or the GHRF Commission, as it's known, included experts in disease control, finance, research and development, health systems, and many more. And they were tasked in creating a global architecture for disease preparedness. The Commission identified a number of gaping holes in local health systems and in global leadership. For example, 196 countries around the globe have signed on to the International Health Regulations, which is governed by WHO. And yet, by their own assessments, 2/3 of these countries are failing to meet the standards that they have legally agreed to. But the Commission also outlined a clear path forward to make the world safer against the threats of pandemic. And I'll outline this path. First and foremost, the path includes building stronger public health systems that can detect and contain disease. That means more surveillance systems. It means more laboratories that are networked with each other, and more clinical capabilities and capacity. But it also means fostering strong social contacts between governments, private institutions, and the citizenry. Second, it also includes bolstering international coordination and cooperation in both preparedness and response efforts. And third, it requires an acceleration of research and development in vaccines, therapeutics, and diagnostic tools to counter deadly pathogens. The Commission estimates that implementing these measures would cost the world $4.5 billion annually, a tiny fraction of what it would cost if we don't invest. Today, the work that needs to be done has to be undertaken in a number of exciting, very important directions. We have to find ways for schools of public health, medical schools, nursing schools, and other schools to continue to press new technologies into being able to do state-of-the-art surveillance and provide appropriate care. Today, the work can take a number of different and exciting directions, For example, at our school and in others around the country, we are seeing investigators harnessing cell phone technologies to better understand and stop the spread of malaria, as one example of using technology in population health. We are decoding molecular patterns that influence how and when people get sick. We are helping health officials and governments, ministries of health, and NGOs build better, smarter systems to monitor and respond to health crises. And we're at the forefront of efforts to identify and stop disease that have not yet emerged. And we're seeing tremendous progress up close with new partnerships, with a renewed interest and effort towards public-private partnerships and collaborations. And we are seeing an acceleration of pivotal discoveries moving from the laboratories out into the field, leading to successful interventions on the ground. But we also have to remain fully aware of the magnitude of the challenges before us. We know that it will take profound political will, financial investment, and global leadership to halt the next pandemic. This conference, in my mind, is a testament to our collaborative social, political, and individual will to do exactly that. And I am grateful and thankful to be here and to be a part of this amazing panel. Thank you.